So, just in case you did not gather it from the chapter title, we will discuss schizophrenia and affective disorders in this chapter. It was right there, but just because I know you don't read chapter titles, I put it right here again. All right, what is schizophrenia? Let's think about a definition on this. It's a pretty serious mental disorder. Typically, you're going to have onset in while you're a teen or young adulthood, right? Okay, so by the time you probably hit late 20s, maybe 30, you're probably out of the woods on this, right? You don't have to worry so much about schizophrenia, right? Doesn't mean that you can't develop it later in life, but typically it's in while you're a teen or young adult. There are sort of three categories of symptoms. They can be a little confusing. I think traditionally folks have thought about positive versus negative symptoms, but more recently cognitive symptoms have sort of been a consideration as well. Some of the things in the positive or the negative symptom category, you might think of those as cognitive symptoms, but we sort of break them out into different categories. In terms of the positive symptoms, now this does not mean they are positive in the sense that they are good. It simply means positive in the sense that they are like present as an extra thing, compared to the negative symptoms, which are the absence of a particular behavior, okay? So when you think about positive symptoms here, thinking about adding a particular issue, one of those is thought disorder, so you have sort of disordered thoughts. It becomes difficult for you to put things together in any kind of coherent way. Delusions are another positive symptom. There are different kinds of delusions. There are delusions of grandeur, so there are individuals who will think that they are, like extremely important or special, that you're not. That you have some sort of special calling, or you're like the key to the world, or what, I don't know, right? There are all these kinds of things. There are delusions of persecution, right? You think somebody's out to get you. You think someone's putting cameras in your home watching you. You think someone's constantly following you when you're out, right? These are delusions of persecution. Okay? And hallucinations, those are another positive symptom. Typically, these are not visual hallucinations. More often, they're going to be auditory hallucinations. So you think about someone who's like hearing voices, right? Okay, they're hearing things. That's going to be the types of hallucinations that you typically see. Negative symptoms are things like flat affect, social withdrawal. So this is going to be someone who's not going to be engaged with other people. And there's some other negative symptoms. Anhedonia, right? So sort of the inability to feel pleasure. And that's another sort of problem, or negative symptom. Cognitive symptoms, you're obviously going to have some cognitive deficits. If you're having difficulty thinking, a lot of your cognitive resources are devoted to, you think people are after you all the time, then you're going to have some difficulties applying your what resources you do have appropriately. Don't worry about that. Here's just sort of the chart showing the onset of schizophrenia. Again, notice that even for males and females, there's sort of this peak, sort of between like 15 and 29 or so. Females sort of have a later peak as well, which is sort of interesting. If you want to look at sort of genetics behind schizophrenia, there's a pretty tight relationship between identical twins, and it's actually no difference really. So this is really really sort of the same. So same number of, so if they're twins, identical twins, and one develops schizophrenia, there's a very, very high chance that the other twin will as well. If they're dizygotic twins and one develops schizophrenia, there's not necessarily a high percentage chance that the other will. So this is actually a pretty big difference here between 17.4 and 2.1%. And there's just showing you dizygotic versus monozygotic. There are a number of reasons, or a number of risk factors, I should say, for developing schizophrenia, especially when you think about from the heritability side. This is one of the few where paternal age actually seems to be important. So older fathers tend to have a higher likelihood of having offspring that are schizophrenic. And this is probably because of mutations in the spermatocytes. There are some epigenetic factors. Those haven't been explored as much. Epigenetics are particularly difficult to study, especially when you're dealing with something like schizophrenia. There are some interesting environmental factors. Season of birth, for example. There are viral epidemics, vitamin D deficiencies, substance use, prenatal malnutrition, population density. All of these seem to play an effect on the development of schizophrenia. So, for example, folks born during late winter and early spring are more likely to develop schizophrenia. We call this the seasonality effect. Not a big deal there. There seems to be an increased incidence of schizophrenia in folks who are born a few months after an influenza epidemic. There's a much higher likelihood of developing schizophrenia if you live in a sort of a larger city, especially if you live in the middle of that city than if you live out in the rural area. Another risk factor is low birth weight. Tobacco use during pregnancy, the development of some kidney issues during pregnancy, or if there are any sort of problems during birth, cut off oxygen, if you have to have some kind of emergency C-section, for example, these seem to increase the likelihood. Doesn't mean you're going to develop schizophrenia, it just increases the likelihood that you develop schizophrenia. So I want to be clear about that. In terms of brain issues, there are enlarged ventricles, you're losing gray matter. That doesn't really tell us a whole lot. Right? It doesn't really tell you what particular brain regions necessarily are reduced, but in general you're going to lose some gray matter, which are brain cells. There are also a couple of sort of what we call minor physical anomalies. So there are, most of these are associated with the face, and then also with the hands and feet. Some of the last areas to develop and more sensitive areas. So you can sort of look at, ears or hair whorls. Like if you have two or more of those, you have a larger head. Your eyes have some anomalies there. These seem to be things that are associated with individuals with schizophrenia. This doesn't necessarily say that these issues cause that, or that the same thing that causes schizophrenia causes this. This does lend some support to the idea, though, that schizophrenia is a developmental disorder, though, right? Because if these are things that happen during development, and schizophrenia can happen during development, maybe some of the same mechanisms are involved, right? Same mechanisms that sort of make sure that your ears are at the appropriate height and that your fingers are not curved and so forth. Those can, those factors may also play a role in brain development, right? Which could then affect the development of schizophrenia later. Not a big deal. This is just ventricle size. Notice folks with schizophrenia have on average larger ventricles than control patients. Not a big deal. Also, you see that decrease in gray matter. And you actually see a steeper decline as those individuals get older. These are actually twins. One who has schizophrenia and one who doesn't. And you can see that there are enlarged ventricles in the individual with schizophrenia. Not a big deal. We do want to think about some of the neurotransmitters that are involved. In particular, it's going to be dopamine. Right? So if you have high levels of dopamine, you're going to develop the positive symptoms of schizophrenia. We talked about this when we talked about Parkinson's disease and treating Parkinson's disease. We said that if you take L-DOPA for long enough to raise your dopamine levels, it will eventually get to the point where you start having some of these positive symptoms of schizophrenia. If you take a dopamine antagonist, which is going to reduce your dopamine levels, you can actually eliminate those positive symptoms of schizophrenia. So at least the positive symptoms seem to be under the control of dopamine levels. The negative symptoms, that's sort of a different issue, but the positive symptoms do seem to be under that control. Okay? All right, questions about that? It's not too bad, right? It's very difficult to tell if someone is having positive symptoms of schizophrenia or if they're just hopped up on cocaine. That's a true story. So for those of you who are interested in working in a clinical setting, I don't know if anybody's in that group. Yeah, so Eric, somebody comes in and they're like, somebody's after me. Somebody's trying to get me. They've got disordered thoughts. They're sort of hearing voices. Do you know if that person is high on cocaine or if they're schizophrenic? The best thing to do is like wait a while and let the cocaine wear off if they're taking it. And if you know they don't take any cocaine for an extended period of time and they still have those symptoms, then you could say, well, this guy's probably schizophrenic. If the symptoms go away and the next time they have the symptoms, it's because they're on cocaine, then you can say, you know, you're having a psychotic episode because you're on cocaine. So there you go. Quick and easy way to test. And more support for the dopamine hypothesis. The more dopamine release that you have a greater increase in positive symptoms when you take these dopamine agonists. So when you give them L-DOPA, amphetamine, or methylphenidate, folks who release more dopamine will have a greater increase in those positive symptoms. There's some idea that maybe there's like dopamine receptors. Somebody had that idea. I'm going to tell you that's not true. And if you read that slide, you'll figure out the same thing. Actually, it's this slide. Now, how are we going to treat people with schizophrenia? We don't really spend a whole lot of time on the negative symptoms. Okay, so you don't really like getting out and talking to people. All right, we can deal with that later. What we really want to kind of shut down is the thing where you think the government's out to get you, right? That we probably ought to take care of first. If we can get that out of the way, Eric, then maybe we can start moving into those other issues, right? But if you're constantly concerned that we're trying to you know, persecute you, or you think you're some, you know, mystical figure of some sort, that's going to be a real barrier to any sort of therapeutic intervention, right? If every time we come in and we try to have some sort of session, and you know, you think I'm just some agent of the government who's trying to collect data on you, and I'm gonna, you know, turn that in, and they're gonna be after you, and they're gonna wait for you when you get home, and I'm not going to eat food that's been prepared by other people because, you know, they're going to poison me, then it's gonna be difficult. So what we can do, though, it's a little tricky, I guess, sometimes, we can give you a dopamine antagonist, right? And so we can actually give you a medication that will lower your dopamine levels. The problem with this is you, at some point, will develop, if we're not careful, what's called tardive dyskinesia. Essentially, this is medication-induced Parkinson's disease, right? So we have reduced your dopamine levels to the point that you have developed Parkinson's disease symptoms, Parkinson's-like symptoms. Now, when you were on L-Dopa and we were jacking up your dopamine levels and you started hearing voices and we said, whoa, let's back off the L-Dopa or try something else, those voices went away. That was good, right? If you've developed tardive dyskinesia and we say, whoa, we should back off the dopamine antagonist, guess what? Tardive dyskinesia does not go away. Okay? It remains. So once you've developed tardive dyskinesia, because you've been taking a dopamine antagonist, it's not going to disappear. Don't worry about this too much. Again, this is just a graph showing you dopamine release increases and increase in positive symptoms. The more dopamine release you have, the higher you rate your positive symptoms. There's some idea that at least for the negative and the cognitive symptoms that maybe there's some what we call hypofrontality, so your frontal cortex isn't really doing its business. Evidence for this comes from the fact that if you give someone with schizophrenia some neuropsychological tests, they don't do well if that test is sensitive to prefrontal cortex damage, right? So somebody who's not had brain damage, they just have schizophrenia, they're not going to do well. They don't have the ability to really focus or maintain attention. All of these things are under the control of your frontal cortex, okay? So those negative and cognitive symptoms seem to be related to frontal cortex function. Don't worry about this too much. What can we do to treat these individuals? Probably the best approach is what we call a partial agonist, okay? Because remember, we don't want to give them a dopamine antagonist because we don't want them to get tardive dyskinesia, okay? What we can do is we can give them a partial agonist. This is something that's kind of like dopamine, but it doesn't work as well as dopamine, okay? So if dopamine works this, like, really well, a partial agonist will work just a little bit worse, right? So it's not quite as good. Not so bad that you're losing dopamine everywhere, but not so powerful that you're developing these positive symptoms, right? So we give you something that's just a little bit, just okay. So if you think about, let's think about something. Most people, as they get older, slightly older, they have a better car than when they were first learning to drive, right? So it's probably not a great idea to buy the world's most expensive car for a brand new driver who doesn't know how to drive. Okay? If you give them a really fast car, they're going to drive it really fast, right? And that's probably not a good idea because they're not very experienced. If you give them a car that won't go very fast, it'll still get them places. It's not like making them walk, right? But at the same time, they're not going to be driving very fast, so they'll be safer. And they can, that's kind of a partial agonist, right? Like an okay car, not a phenomenal car. So there you go. That's an idea. Keep that in mind. Don't worry about any of this. I'm not going to ask you too much. This is, again, how a partial agonist works. It competes with the normal neurotransmitter there. It will bind to some or all of the receptors, right? And displace those. Okay. And in that case, it will work, it will reduce the effectiveness of the dopamine, not to the point that it shuts it down, just to the point that it brings it down to a normal level. Okay? If we want to think about affective disorders, there are two major types of affective disorders, what we call bipolar, right? It's kind of this cyclical period of mania and depression, and then major depressive disorder, which is this unremitting depression. Does seem to be fairly heritable. Most neurological disorders or diseases do tend to be that way. There are a number of genes that can be involved in that. I'm not going to ask you too much about it. How might we treat these approaches? Sort of older approaches were monoamine oxidase inhibitors, MAOIs. How many of you have ever seen a medication box that said don't take this if you're on an MAOI? Yeah, they're pretty much on every medication. If you're on an MAOI, there are other things you can't do. You can't drink wine, you can't eat cheese, which I know you guys go to a lot of wine and cheese parties. So that's going to, you can't do that. There are a lot of dietary restrictions on MAOIs, and tricyclic antidepressants have a lot of nasty side effects. Primarily now we give folks SSRIs, selective serotonin reuptake inhibitors. We've talked about this, just blocking the reuptake of serotonin. Okay. Ketamine also seems to be fairly effective for treating depression. Not something I would recommend because, again, it's going to screw up with that sort of learning and memory process. Things that don't work as well. Well, lithium works well for bipolar. Things that are a bit more invasive, but sometimes necessary if your issue won't respond to other approaches. You can do some electroconvulsive therapy. This is not one flew over the cuckoo's nest kind of business, right? So this is kind of different and safer and so forth. Transcranial magnetic stimulation, which is kind of cool. You're using a magnet to turn on or off part of somebody's brain. Deep brain stimulation, those are other approaches. I mean, here's ketamine again, very effective at reducing depression, but very effective at reducing memories as well. Keep that in mind. Don't worry about the deep brain stimulation stuff there. Hyperactivity, frontal cortex. You can skip through this. Affective disorders, again, there seem to be monoamine issues, nothing to worry about there with serotonin. Again, if we increase serotonin levels, we seem to reduce depressive symptoms. There are some issues with circadian rhythms in individuals with affective disorders. A lot of folks with depression have disordered sleep. So sleep deprivation is actually a highly effective treatment for depression. Again, this is not a good long-term solution, right? Because you can't go without sleep for an extended period of time. But it does seem to work, in the short term. So I wouldn't recommend trying this on your own. Like, boy, I'm feeling depressed today. I'm just gonna stay up all night. I don't know. Yeah, Robin, don't give that a try. I don't know if that works, but it does seem to be effective. There you go. Total sleep dip. It improved mood in two-thirds of the time. It improved mood, which is pretty effective, right? Like 66% of the time, sleep deprivation will improve your mood if you're depressed. So I know, right, Regan? That's kind of like, well, I don't know if I'm going to try that. You guys feeling down during finals week? Try to stay up all night. I wouldn't recommend it. Don't listen to what I tell you most of the time. Okay, no worries there. We could talk about seasonal affective disorder briefly. This is seen in individuals. Typically, it's related to changes in the amount of light that you're exposed to, right? And so phototherapy seems to be a pretty effective way to solve this. So the next time you're feeling depressed, stay up all night and shine a light on you, right? just get a big spotlight and hold it right on your face all night long, Abby. Guaranteed to feel great tomorrow. And especially if you throw in a little ketamine. Did I mention that part? So if you do all three, guaranteed to cure your depression. Nobody should try that. I'm just going to be honest with you. But seriously, living in total darkness does have some serious effects on your monoaminergic systems, which is like dopamine, norepinephrine, and serotonin. You can see considerable decreases in those neurotransmitters, right? So there you go. Yeah, let's not talk too much about melatonin. All right. Anybody have any questions about either of those chapters? Awesome. That leaves us with, what, like 2 chapters to go? And we've got 2 weeks to do that. So that's going to be great. We're right on track.
Those chapters are really short too. Right?